and welcome Saeed, welcome here.
Thank you much.
So it's a pleasure to have you here in India.
Thank you.
Yeah.
Sunbeams forming a shadow for a field. We're floating, just carried by levity, sensing a feeling of love through every
Five surgeries now. So for the first OT we have RIRS by Dr. Saeed Bin Hamri. The OT moderator would be Dr. K.M. Nanjappa. And can I please invite Dr. Abdul Latif, Dr. Karthikeyan, Dr. Vikram Sridhar, Dr. Ganesh Kamath and Dr. Shailesh Bajaria to moderate the session. Please.
Dr. Sharik?
Yeah. We are eagerly waiting. Yeah, thank you for, I think, connecting. Okay, so we'll go ahead with in the OR1 here, the left-sided RIRS. The case is about 45-year-old gentleman, and I think he has a left lower calyx stones. Two stones are there. One is 10 millimeter, one is 8 millimeter. And I think Dr. Hamri is going to present the case. He's going to demonstrate the case, and I'll invite Nanjappa to please take over.
You want to present the case?
Patient is 45-year-old gentleman presented with left lung pain for 2 months. On imaging, patient was found to have a 8 mm stone in pelvis and 10 and 7 mm stone in lower calyx. And also patient was found to have right side small kidney with gross hydronephrosis, which on DTPA was found to have non-functioning kidney. So plan is left RIRS.
Good afternoon everybody and welcome Saeed, welcome here.
Thank you much.
So it's a pleasure to have you here in India.
Thank you.
Yeah.
Do they hear me?
Are you hearing Saeed?
Yes.
Yeah, we can hear you.
Excellent. Saeed, first we would like to see because the setup. You can go on with the setup.
Yeah,
and
I like to walk alone. This is what we will present now. This is a single kidney. We will walk in a table.
Can you increase the...
Can hear you, Doctor.
Okay. So basically, this is a patient with a single kidney. It was an impacted stone in the upper ureter pushed by the body stent to the lower calyceal system. Now we started always the table below the level of food. What is interesting is this operation. It's a single kidney, but we will do it without X-ray. Okay, we will just demonstrate the weight of fans using an access sheet 40 centimeter, which is okay for his leg, 10-12, and we will use a scope 7.5 from red pine. Now, the thing that I always interesting in your guide is the guide wire. So if you notice, I like the Tirbu, which is a pure hydrophilic guide wire, and you should not use the soft or standard. Use the stiff one. Look, it's completely erected standard. But if you look to the guide wire, the normal one, you can see it's falling down. So hydrophilic guide wire, we have 3 types: stiff, super stiff, and the standard. So do not use the standard. They're being used by the vascular surgeon. So as you can see, this is a pure hydrophilic coating. We put it, basically what we will do, the double distance is outside. I work almost with my nurse on my right side. Everything on the table. I think this is a 6 French. Okay. 6 French, 2 months, a little bit encrusted. So if you notice that my nurse is holding her hand on her body and my table is here working. So I push the guide wire, then I fix the guide wire. I fix the guide wire with a gauze, simply gauze. I push the guide wire, then I feel some resistance. I'll push the double distance, which is coiled in the upper coil. I'll remove it gently, not to push the guide wire away. Make sure that the double distance is going on, the guide wire is going on. Now, if you notice that it's a little bit away from the table, we'll try our luck. We'll see if it goes. This is almost 6 French, so it's not really encrusted. Now once I reach here, I'll just hold the guide wire out. No, the guide wire out because of double distance encrusted. So we will have to put it under the loop. So again, look at the double distance. cannot slide over a pure hydrophilic guide. So it doesn't mean that you have a hydrophilic guide where it's a good double P stent is being crusted. This patient has bilateral stones, so he's a high risk of stones. He lost his right kidney because of the stone. I'll put the guide wire in the snail again.
Saeed, here, if you use fluoroscopy, is there any chance of just using fluoroscopy here? Or you
Yeah,
would
if you
prefer
want,
to use?
if you want, but I will do it under vision. So the double G stent trouble dust, this is where comes the troubleshooting. So we have to put the guide wire also, and then we explore. Can you have light please in the scope? And then if you notice that I use a system from Procamed, it's a system of irrigation. We'll have a manual assisted system that you don't need a syringe. Light please. So immediately we go inside the bladder.
Can you all have an endo view there?
Do you see it?
Are you all seeing an endo view in the auditorium?
Yes, yes.
So now this is the, we can open the water, close the water. Now we will see the orifice, it is a little bit edematous. Yeah, the view is good. Okay, can you push some water please? Push some water. Yeah, you see my nurse is trying to push some water. So just open the meatus. And then we'll try to go slowly until we see the lumen. So this is the lumen. The ureter looks prepared. We are in the mid of the ureter. Stop washing. Now we explore the ureter. There is nothing, no incrustation or any fragments from the stent. Now we'll put our guide wire. Please put it complete. Just put the water here. Everything on the table. Then I close the water here. My assistant will try to put the guide wire inside under vision. Now I will open the water just to cannulate the ureter. As you can see, you can do the X-ray if you want to make sure that everything is fine. Now if you notice that my guide wire has a third of the table. Now we will put our guide wire. Now these are troubleshooting, so it's okay. This guide wire fantastic, it does not bend, it's a stiff. Once I reach here, I will hold my hand here. Do not worry about the guide wire. You put your scope on the table, and then again you put it. Once you reach a 2/3 of the table, you are inside the kidney. I will show you if you want to make sure that you are in the kidney. You just explore the ureter. You know that your guide wire is inside the kidney. Okay. Now next step is to use the access sheet just to make sure that the guide wire for you guys in the kidney go in the right kidney. No, because yes, go up here. In the right, in the left hand condorium. Yes. Now you see my guide wire in the kidney, and these small fragments is there. Now we will push the fans into the kidney without X-ray. Okay. So the trick, if you have a nail, you have to stop 45 to 50 centimeters. Stop at the meatus. It doesn't matter too much about the length of the patient, but you will be sure that at least if he is 180, 150 centimeters, you'll be sure that you are in the upper ureter rather than the kidney. But make sure that the patient, if he is under 150 centimeters, you might perforate the kidney. So it's about sensation and feeling. You notice that I walk alone? No nurse? Please come. I'm not trying here. So now we will push the access sheet smoothly. We put an engine tube, small engine tube to empty the bladder to facilitate things. Now if you notice this guide wire is very stiff, it will lead you, you pull the penis, you put your finger here to cave the introducer inside. Look, I will just until the meatus. Now if you do the X-ray, you will see that at least I'm in the upper kidney, in the upper ureter. X-ray to show them, please. You see?
Do you all have a floor?
I'm almost in the renal pelvis. 45 centimeter to 50 is good for male with a reasonable height. For female, maybe 40 to 45. But we are inside the kidney. Do an X-ray again just to make demonstration. I don't do X-ray most of my cases.
Dr. Saeed?
Yes.
Sorry to interrupt. This is Dr. Karthik. you have nicely put the access sheet across the PUJ.
Yes.
Is it okay to cross the access sheet across the PUJ without visual guidance? Usually we pass the flexible scope and over the scope we'll advance the access sheet.
The trick is to reduce the time. The trick that if you guide well inside the kidney, and the double distance there, the ureter is pre-stented, so the ureter is compliant. And you have to feel it. If you have some sort of resistance, you have to stop and go back with your scope and explore what's going on. But you are right. Sometimes for the beginners, we advise them not to do such way. You just do retrograde. But I'm showing you that it comes with the experience that you might reduce the operative time, reduce the X-ray as possible, because X-ray is dangerous. We don't think about us. We've been, as an endourologist, you are doing 200 to 400 procedures. So you are really exposed to the X-rays. You see that guide wire is left inside the snail, and you can see clearly the urine coming from the sheath of the other side of the sheath. Now we will take this off, and this is from a mediago, and we will pleat and put it here. Then you can see clearly the urine come here. You are safe. You are in the renal pelvis. We use the rubber. Some companies they put integrated rubber inside, like Univex. The other company they give you this rubber. You have a self rubber. Then we can have some suction, please. The tube of suction, please.
Which brand fan sheet is this?
This is 10, 12, 45 centimeters. So this is the thing for the suction. Some companies gives you valve, but here you have an open window, so you can use your finger to just close it and penetrate the. And always do not put the suction down, otherwise it will pull your access sheet out. So keep it at the level of the patient. This is a huge tube, but we didn't use this one. What is the other one?
Yes. Dr. Syed?
Yes.
In the female, there's a tendency for the sheet to slip out.
Yes.
So is there something which you do additional?
That's why you have to, in the female, use a short access sheet, 40, 45, instead of having long outside. If you have a long access sheet fans outside, it will fall. Because most of the 30%, 40% of your access sheet, if you use 55 for a lady, 160 centimeter, half of the access sheet will be outside. So with the manipulation, it might be slipped. That's very true. That's why you have to know what access sheet length you use. Some companies from fans, they give you the inner part, which is with the straighted numbers that you can measure the ureter. Right.
So do you always use a fan sheet nowadays, or do you use the normal access sheet also anytime?
Listen, the access sheet with the fans showed perfectly in the publication with the hemotherapist. It is a very useful device to help us to go to extreme stone free, especially with a guy with a single kidney, strobitis stone, cystine stone. It tells us we don't use the basket. Basket a little bit dangerous. The only thing against the fans is the matter of stress on the junction. The junction is about 2 millimeter, 3 millimeter. So that's why we abandon fans 12, 14 French, because of two reasons. Reason that you are manipulation too much of the junction. The other one is that 12 French is big to do the suction. So once you go thinner, it's much better. 8 to 10 French act fans is much better than 10, 12, but we don't have a scope. We need to have a 6 French scope. We need to keep 2 French to 3 French between this scope and the access sheet. Otherwise, it will be trouble. If you use an 8.5 French with a 10 French, you have 1 French. So there is a question about the pressure. Now this is a scope from Red Pine. It's a 7.5, 7.4. As you can see here, it's an American. Down is down, up is up, and the complete deflection. Beautiful, 280 almost, and the other one is 285. Remember that if you tackle a lower pole stone, you need to have a new scope always, because the new scope will give you the torque and gives you the deflection, because you are not deflecting only the scope, you have to deflect the 10-12. If you tell me that I need to use a 12-14 fans with a 7.5, it's very small. It will be very tiring for the scope to bend the 12-14. It's much better for it to bend the 10-12 rather than 12-14, because 12-14 is like a truck. Okay? So, where's the urine? Now, I use this system, the port seal is there. You can see, you can inject contrast here, you can put the laser here, you can control the irrigation. We'll take the irrigation from the semi-rigid.
The irrigation system is the Traxa flow.
Yes, it's a T-flow from the interconnector, please here.
And
And
this-
then my assistant will help me to create a venturi. It's not only the section, it will, hold this please, hold this. It will help me, the venturi with the section, to eliminate the stones, as you will see now. Now, the pump here in the middle of the table for my assistant. Okay. Now the gravity will work in the gravity. As you can see, the water is up. Can you raise it up? Because this is a 40 to 50 centimeter, which is accepted. How much the section in the wall, right? We put the section at the beginning at 10. We want to inflate the kidney. We do not surprise the kidney by high pressure. We put 10. Can you put 10 in section, please? And the assistant will push, pulsatile pusher like this. And then, hold this please. My assistant will be to hold the scope, then we insert the scope inside the access sheet. Can you see the endoscopic vision?
Yes, yes.
Okay. Now we go, we hold the access sheet by 2 fingers here not to slip, and we use the 2 fingers, the thumb and the index, for pushing the scope inside. If you notice very clearly, there are 10 centimeter outside the body of the system. Look at this. This is the flexible part of the fans, which is the most vulnerable to be broken. That's why I advise people when they start doing fans, do not reuse them multiple times. Use a guide wire as a safety guide wire. I have seen cases, broken segments inside the kidney because of multiple use. We are almost in the...
Can you focus on his hands, please?
Yeah, you can see that I push the access sheet across the junction, and then I close my hand. This is the left kidney. Then you will see this stone jump from the, I think jump, you can wash. You can see that I can move the stone with the washing by the nerves. And we give it a time. Yeah. Now it's in the upper calyx. I will show you now. I push this sheath into the upper calyx. I open my hand. I'll find the stone here. I will look for the other stone. These are the 2 different stones. As you can see, do X-ray please. I will just show you how easily Reptile could deflect the 10 French easily. We are almost in the lower calyx.
How is the vision? Are you all seeing the endo view clearly?
You see the endo view. This is a very, yeah, you can see how beautiful. That's the mistake. You cannot use a 7.5 with access sheet fan tool 14. Because it's so big, you cannot bend it. And if you use a 6.3 with the access sheet tool, you have to remember that 6.3 is so soft, it might be broken. So you will lose your scope. You have to have this equation. So the access sheet was successfully bended into the lower calyx. The other stone escaped down, but we will start with this. These kind of stones, truly metabolic, calcium dihydrate mixed with the appetite. So the laser fiber, I already prepared it, as you can see here with doses, so I don't need to much of the movement. So I will take the laser fiber with my 2 fingers here.
What's the size of the laser fiber you're
This is
using?
a 200. I will close the water here. I will open the ports here. Now, I will make sure the port seal is working. You see the water. Then I'll hold it, the 2 fingers in my just to stabilize the fiber.
The AIE team, can you zoom on the sir's hand as a figure picture and the end image as a picture image?
We slowly going with the fiber, not to perforate the working channel of the axis of the scope because you are in deflection. So you have to go easily. Do not trim it. Keep it with the blue cladding. You will see we are arriving. Now you can notice that my laser fiber on the right, on the left of the leg of the patient, easily. It is not easy to use the American after you used to the European, so you have to use everything to be an expert how to manage. Now, if you have any difficulty to insert the fiber, you have to open the water and go back to straighten your scope. Go back, straighten your scope, and then insert the fiber again and again and again until you see it.
So even in here.
Here we go with the fiber here. You just keep it. I will ask the anesthesia to give me a sanapnea. You can notice that my assistant is washing with a manual pulsing. Now we will go to the lower pool. I will see where is the lower pool.
So you use a stripped fiber or you like to have a unstripped fiber?
This is the stone, the big stone that was impacted. You can see it here. Yeah. Now I put the thulium in 0820. This is my preferred setting. Don't push too much. Just slowly. I prefer 06 to 08, frequency 15 to 25. Never cross the 30 watts. You don't need more than 16 watts. As you can see here, 800 millijoules from fiber dust and 20 hertz.
AV team to focus on the laser machine, please.
So Dr. Saeed, this is TFL, right?
Yes, this is the TFL. If you come, I will start and the section, I can put my finger here and you will see that all fragments coming with me, because TFL gives us a very small fragments, less than 100, 200, which can pass by through the kidney. And of course you need some sort of technique. Can you do me apnea, please? You have to some sort of technique that to have a big fragments. Otherwise you'll be in trouble to going in outside many times to have these fragments. Look at these fragments, stop to the scope. If I go back, they will go back to the scope. But if you have a lot of fragments here, you might obscure or obstruct your access sheet. Look at the vision, the flow, the pressure. It's true that it's a pre-stented kidney. Can you do apnea please for me? And the technique is not to touch the stone, otherwise you'll have more fragments. Just paint it from the edges to the surface. These are very fragile stone, it might be broken to pieces. It's okay, you can give them. Look at these fragments. I can go back again. I'll leave them again. You wash please. Wash over.
With fans in situ, do you prefer to dust or fragment?
I like dusting because all the dust will go between the sheath and the scope. If you can see these fragments are available, you can pull this out, and then they will come with you. Then you go in because they will go behind the scope. These are very small. Look, they go between the sheath and the scope. Now again, we go to our stone. Look how the suction helps you. Even small stones. Look, they follow you because of the suction and the Venturi effect done by the nerve. I go back
The suction connected to the central section.
to the central section. What I advise people at the beginning that use thin in the wall section at the beginning. Then you can, once you finish, you can put 50 to 100. You cannot surpass the gravity. The gravity gives you 70, 100. If you do suction more than what you irrigate, the system will collapse and the bleeding will come, especially if the kidney is suffering under pressure. This kidney is compliant because it is pre-stented. The patient was obstructed, so the hydrophos is there, so the kidney she knows the pressure because it was obstructed. And then look at this stone. Can you change the light if you want? And then we do some sort of painting at the edges. I don't want any fragments. I just move my hand and you can see all the dust will be suctioned outside. And then I just move my hand, the three movements, micro movements, supination, pronation, in, out, upward and downward. And then the sheath, it might be at the edge of the scope, or you can liberate your flexible litoscope and leave the sheath outside. No, you don't need it now until you finish. Then you do the vacuum. As you can see here that I'm not trying to do fragments. Despite that, I have these small fragments, which is okay for me. We know that the stones is not the same. They have some fissures. Even with the teeth in, might have broken, but you have to do your best not to have a significant fragments. Otherwise, you will be in trouble to go.
There is a disturbance in 41.
This is look beautiful. This is only 16 watt. That's why we don't advise to go for hertz more than 20 hertz. And go from the edges, slowly, take your time. Believe me, it's a 10 minutes for 1 centimeter. Apnea, please. And you can notice that my nurse does not use a syringe. She is happy.
What's your pulse width setting? Do you use only a long pulse width or a short pulse width?
Short pulse because we need a peak power, 500. Long pulse, you might go to 200.
So in TFL, it's always short pulse.
Always short pulse. It's not like the holmium we go with the long pulse. Pulse modulation has nothing to do with the TFL. It's all about peak power. 500. And then you count the stones, you see that the TFL is like a Ferrari. Nobody will like it except an endourologist because you need to be very close to the stone, not to hit the stone, not to have a charring, not to fragment. And these are small bubbles, so if you do it with a distance from the stone, it will never affect the stone. So you have to be very close to the stone.
And we are really enjoying the way you are driving your Ferrari.
No, it's like people, they don't like the, look, this is stone fragmented. People, they don't like the TFL because of two things at the beginning, because they use the high frequency. So all the sharps coming out. But then the other point that the holmium bubbles gives you a big bubble that it will break stone even from distance, even for the junior. If they use the holmium, it will break the stone. But the TFL, you need to be close like this. It's an ablation power. The absorption of TFL, it goes ablation. The holmium just explode the water particles between the stone composition. Look, these are the kind of stone. Let us do popcorning. Popcorning is the same in the TFL. Do not change the setting. There is nothing called popcorning. You don't wash. I will ask my nurse not to wash much, just not to move the fragment away from my needle. Okay? Even if it hit now. These are stones here. I will just hit them. I will wait for 30 seconds. The TFL has no retrograde. That's why the stone will never move. Look, it moves with a minimal retrograde. And this is a beautiful scope, by the way. It's stable, the torque is good. Look, I move my hand right, left, it obeys me. There is no problem. If you just estimate visually the fragments here, look, compare it to the laser fiber 200 micron, which is 0.2 millimeter. So let's multiply these fragments by 4 or 5. So this is 1 millimeter, or maybe 500. So it's like, look, and now do the suction please. Suction please. How much?
When you suck and the fragments come between the scope and your access sheet,
yes.
Does the movement of your scope become slightly impaired?
No, why?
Because sometimes the scope gets stuck?
No, you see these fragments, it come up, wash. Now my nurse is helping me by washing with a single look. She's pushing one. Do not do pulsatile. Do one, empty the one, two. She's doing a flow. If she does pulsatile, the stone will escape. The water has to come behind the stone and bring it. Do it once, only once.
So I think the speed of which you retract it is also important.
Yes. You see the nurse, you can put it over the table and do this one, like bend it, only bend it like this.
You will always keep the stone under revision so that the whirlpool is maintained.
Exactly, you have to have the water, wash.
Literally like a virtual basket.
Now she escaped. So how much the suction please? Can you put 30? Now I will put my finger to help my nerve. Oh, the stone escaped, right? So I will put my fingers here in the sheet, then she will wash. How much the suction? See, I will put my finger so the stone will follow me. Wash.
So you never use an assistant for this? You do it all by yourself?
Yeah. You see? I don't use an assistant, I'll fix my access sheet, then the nurse will push a water, she's emptying it. The stone is a little bit big, so what I will do, I might just try to manipulate, it will come. No. Yeah. Now, wash, empty the room, yeah. Now,
do you have a need to basket it within sometimes?
Like, listen, the basket depends on your assistant, he has to be trained. The basketing skills is not easy. Sometimes you are shouting, but you are doing everything by yourself. It's a self-basketing by the access sheet. You can see that big fragments went easily to 10, 12. Now the upper pool, look at this.
Do you never use a basket, Saeed? Or are you ever using a basket?
Very rarely, even if in the lower pool I can deflect my access sheet to the lower pool easily. And look at this fragment, this one. Yeah.
Some of the access sheets have curves at the distal end. Do you find it easier to suck?
To what?
Some of the access sheet has cusp-like things at this end. Do you feel that the suction effect is better in those type of access sheets? The distal end, which is inside the kidney or the prostate.
Yes, okay. Look, I understand. Look, these access sheets are very soft at the beginning, but the company enforce it because they have a problem with the softness of the tip of the. Before it was like a whip, but now if you notice the first generation of access sheet, it was not coiled. It was very soft like a rubber of the car. Now, because of these problems, they enforce it. So the tip is not yet soft like the third generation, but it's not, look, it's very soft at the edge. The edge is okay, but they enforce it because they are afraid of leaving the tip of the access sheet inside. Yeah, you can see all these fragments coming out. I go inside. My access sheet already in the area here. This is the single kidney. We have to be cautious about leaving any fragments. You can see here this section, please. How much section?
What is the brand of access sheet you're using?
This is the, I mean, you have the 80 brand in China now, 82. You have ZSR, you have Mediago, we have this Mediago, you have a Clearvitra, you have a Macrolix, you have a Civlo. You have
the one you are using now?
It's a Mediago.
Okay.
They're from, I think, from Hong Kong. They have the machine to measure the pressure as well.
This is 10, 12 and 45 centimeters.
12, 10, 12. But if you notice that 45 centimeter is good, I'm inside the kidney. If I use a 55, I will be working here in the tip of the skull. This is a wrong message that the length will be, you will aspirate all the fragments all the length of 55. So it will be trouble moving the fragments all this distance. The other point, the 55 will be reaching your tip of the scope here, so it might be burnable. The other thing, you will walk away from the patient, especially if it's a female. So the access sheet, if it's not hydrophilic, it might be slipped out. Now, if you see here that small fragments, how much the section, please? Look, I am using like a vacuum. You can see here clearly. Now these fragments will come outside. I'll wait until the system accepts me. Notice that this is a new access sheet, but look, the inner part of the sub-access sheet being lost, the hydrophilic coating. So be cautious of these retained material. Always examine your instrumentation after each operation. Otherwise, you will keep some. Yes.
So for how many cases do you use one access sheet?
Oh, that's a forbidden question.
So
you know, I can't blame people, but I have pictures of missed access sheet inside from countries that use it. But I've seen an access sheet from Navigator in 2012 being used for 1,000 times. I swear to God, there is no hydrophilic coating, only the plastic. So the surgeon was like pretending that it goes everywhere. There's no problem. I don't know.
So you strictly disposable.
It is disposable, but the problem, they are burnable at the beginning, at the end. So multiple use will have these fissures in the tip of the access sheet. So with a tight ureter, not prepared ureter, it will stuck, especially if you lose the hydrophilic coating. So the ureter will bite your access sheet. The tip is burnable. Look, this is the segments where the most burnable, like the scope. Look here. It might be broken, especially if you go beyond the junction. So you bend it a lot, This is the part, you see it? Yeah. This is the part you might leave it, especially if you go 6 centimeters doing load pull, doing too much manipulation in a used access sheet, it might be broken. And then the scope, I have something in the scope, will be stuck in the inner part. So get me out of that ureter. So I think if you're reusing, we have to know that companies are not the same. Companies, they are cheap in the hydrophilic coating because it costs a lot. So some companies, they give you very bad quality because it's single use. But if you want to reuse something, you have to go to a good company. Like, okay, I'll accept it one or twice, but you have to test it. You have to have a special nurse that she knows that she knows your instrumentation, that she knows, doctor, this is defective, I cannot use it. You've been helpful by guys around you. You cannot work with different nurses, different people. Look at these fragments coming easily.
Got it.
The presence of your laser fiber inside doesn't matter?
Doesn't matter because I'm hitting the lower pole. So if you can see, these are all the upper pole is. You can see clearly that the suction fans bring you the stone from inside. The only thing that the miners will push the water, So the water, look at this fragment, the water will roam around the system, then the suction will bring these fragments to you. You don't need to follow them everywhere.
So when you come out, you stop the suction as you go
Yeah,
in.
look at these fragments, look at this fragment, they come, suction please, put me the suction. Now this is the difficult part that you have to follow. This, for example, suction please. How much suction? Okay. No, put me 50 please. Yes.
Dr. Saeed, can't you control the suction with your hand?
Yeah, with the nurse, no. You can. Yes, I can handle it, but I need more suction. That's 50 to 100 at the beginning, at the end. But look, these are small fragments will pass between the scope and the sheet. Come, you have to go outside and come again.
So what is your cutoff size for regular RIRS and fans? When do you use fans? When do you use regular?
I like to use the fans if 16 patients through vital stone, kidney impacted. I don't know if there's a pus or something. Big stone. I don't use it for 7 millimeter or 1.2. I use it for a high volume burden stone like 1.8, 2.5 because there will be too much dusting. So, and fragments will be everywhere. So the dusting is clearly, like for example these things, I put my finger in the sheet.
So if the system is too dilated, do you prefer fans in that case?
It does not matter, yeah, clearly. But the system dilated will help you a lot because the kidney is already submitted under pressure. So the kidney complains towards the pressure. But if you have a virgin kidney and a 2.5 centimeter renal bulbus, you have to take in consideration in the beginning, do not put too much fluid.
Hello, Dr. Hamri.
Yes.
Just a minute, there's a question from the audience.
Yeah, Dr. Parimal here. I'm finding that during the lasing and coming out with the laser fiber in situ is causing a problem. There are alternative strategy. What do you think that do you do the dusting and all the fragments can be sucked out at the hand or in intermittently?
Yeah, hi Parimal.
Hi.
I agree with you. It's upon your technique, what suits you. Some people they like to do the whole fragmentation, then they do manipulation. The problem that with the too much in-outs, with the suction, you too much manipulate the ureter. So I apply to, at the beginning, I like this fans to be stationary, like a normal axis sheet. Then when I start and the dusting will go out, if I start fragmentation, I mean that I will go inside the kidney, so too much stress in the ureter. So why don't I use dusting and stabilize my axis sheet, but at the end I start to manipulate. But instead of manipulating the whole procedure. If you can notice that I put my axis sheet in the upper wall, I did not go to...
So is that not the exact reason to keep the access sheet below the PUJ when you dust, and once you complete dusting, you put the access sheet across PUJ?
Why not? It's a good idea, but you will have a problem with the pressure. Because sometimes...
Saeed, are you still worried about the PUJ with the access sheet across?
Listen, 10 French is acceptable. 10, 12 French is acceptable. I'm worried about big instrumentation, especially for non-prestented ureters.
Here in our side, we see that even with a stent, sometimes our PUJ is non-accommodator. So, do you recommend that we use a fans there or no? Never cross it?
Well, it depends. This is a pre-stented patient, so I'm not worried about it. But if you have a stent very fine, you can put the access sheet at the upper ureter. You finish your job, then you slide it in and then you walk. But this is a pre-stented. Let me just show you the junction. Look, the junction. You can see I pulled my access sheet, and this is the junction. It looks healthy and fine. You can see it clearly. So it depends on you. We cannot push young urologists. The fans will do the operation. You have to test everything. You have to know everything. Otherwise, you will be in trouble. As you said, these are very nice remarks. And now we are in the lower pool, as you can see here.
Said in your series, how many of the primary fans do you do?
You mean
without presenting?
Oh. Listen, it depends, because I know in India it's a little bit tight ureters, like in Saudi Arabia. So I think it's almost 80%. in my country, but I know in India they have a very tight ureter. That's why if you use a big instrumentation, I think pre-stenting is good. If you go to Germany, they have access sheet 14, 16, 16, 18. I've seen it from Eurotech. Imagine that you have an access sheet 16, 18. It's like a mini pair.
What flexible scope they do use for those kind of bigger access sheets?
They use Olympus, 9 French, they use Fusion, but anything from the old. But I think that was in 2014-16, but the company still manufacturing these because I think the Germans, they drink a lot of beer, so the ureters are very wide. It's not like in Saudi Arabia.
It's like a free medication you can advise.
Yeah.
So do you have any apprehensions about the access sheet being made smaller in size? Now see, there are companies making
now I
access sheets.
received an 8, 10, 12,
Yes.
10, 8, 10 French, which is very nice. The structure is very nice. The problem that you have to use a scope which is 6 French. We have 6 French from Siblo, Civita, and I think the third company, but 6.3 is not as well. Redpine they have 6.3. I think Kandar will show you the 6.3, beautiful one, but haven't received it.
So do you think that doing fans with a 6.3 the scope
Yes,
takes a lot of toll?
Look at this big fragments coming from the lower pole. Now, it's stuck here, so what I do, I will ask my nurse.
Do you ever
Now,
lace
I will
inside
pull-
a fan sheet?
You can use it, but you have to be cautious. Look at this big fragments, it should come.
So if you are going to fragment and set, so do you feel whole beam is a better tool in that way?
Well, the TFL gives you more dusting, so you don't need to chase the fragments. Look, this fragment coming from the lower pole, you can laser it inside the access sheet, but be cautious, and it will come. You ready to decide. One of the tricks, do not suction while the access sheet in the lower pole. You have to repress, pull the access sheet to straighten it. To make the suction is much better. Now, I will put my finger here for the suction, and these big fragments, we used to take them by the basket. Now, I use it, only my nurse is doing pumping. I don't need anyone to fix my access sheet. Now, she might hold the scope for me, like in this, hold this one. And then I will try to pull, because this is the area where we take the stone out. Yes, the stone is out. Yes, slow, ready. Yes. Now I go back. As you can see here, we did not use the basket. Especially we can locate the stone by the basket, but if you have a very nice access sheet and very nice scope, 6.3, 0.5, I believe in that 8 French, 8.5, 9 French scope will die. The future is 7.5. That was published by Bugley 20 years ago when he said 7.4 is the 99% of the success access to the ureter. So I think 7.5 will stay as the major on the market. 6 French, 6.3 will be so indicated in specific cases like pediatric, because of the vulnerability and the durability. Because if you do 2 centimeter stone with a 6.3, you might not finish the operation. It is very soft. It's a very nice device, but you cannot make it for the hard work. 7.5 is enough for you.
So as we continue the fragmentation, we do see a little bit of ooze in the system.
Yes, this is I think this stone is impacted here, but this is also because of the edematus, and this is that the stones are here impacted in the system. Look, if I find it difficult, I will draw my access sheet, as you can see, to liberate my flexible scope to work easily without putting my access sheet to prevent the scope from working. Look at the torque of Redpine, beautiful. It goes to it, just more.
Your working channel position also mattered here?
Yeah, sometimes, because 9, I like the 9, I don't like the 3. You can see this stone was impacted in the cranial system. Now, this, I will do some, no problem.
So your experience with the stone sense, have you used it?
Yes, I used it 3 weeks ago. The problem with the stone sensor from PPG Urolaze, that if you have such a stone here, it does not work because the sensor tissue is very high. So the efficiency of the laser is low. If you hit an impacted stone in the ureter, it's not practical because the system will shut down only from then to then. So this is my just remark on the sensor tissue, but it's good for the beginners, for the juniors to start, and instead of having difficulties learning, because and we know that we limit the frequency, we know that we limit the power. So that sensor is not very something nice, but I like the ultra pulse, which is a mode for the TFL when you break the stones, very nice. So my TFL, if I bring it, I will do the PCNL with it.
Sometimes the small clots within the system will form a coagulant with the stone, and it will be difficult to suck out.
True. And then you can notice that the TFL has no retrobulging, so the stone is still alive.
So you have been setting the pressures quite a bit. So, and you're saying the suction settings. So do you think the automated system which has come of what's your experience with that? Have you used that? The automatic pressure
yes,
sensor?
it is complicated for the nerves, but it is very nice. I use it from the Urology this hour. It is nice that you know the pressure at the beginning. The only thing that we don't know the pressure, what time happens at the beginning of the procedure or the end of procedure. As you can see, this is an impacted stone inside this calyx. Now, suction will help me to remove these fragments. I will go down to the lower calyx. This is the upper calyx.
So what is your feel about the life of your flexible scopes with
It's very nice, very nice, it's very light. I don't know how much, 35.
after fans?
What do you mean?
No,
He's asking how many cases can you reuse your scope when you're using it for fans?
Again you say...
They will kill me, they will kill me. Listen, I cannot declare it, but I think flexible...
Nobody's hearing, you go ahead.
Listen, you cannot use it for 10 to 12. You cannot. I think companies make you 4 hours. So it's a 4 operation because flexibility is between 1 to 2 hours. But I think the 4th operation, if you have a partial kidney, pelvic kidney, pediatric patient, you cannot use the scope. You might be successful in one case, but use the scope are burnable like the cars. And after 10 miles, it's not like the first mile. So be cautious with reusing your scope. I don't mind it for simple case. I selectively reusing scope for example, residual stone. I go inside, I take 5 minutes. But for big operation, I have seen cases, the tip of the scope broken inside the kidney. I have put videos. I have seen it.
Saeed, this is Kandar here.
Hi Kandar.
Hi, how are you?
I love your theater. Beautiful.
Thank you so much.
I will work with you here. You have been assistant.
Yes.
You want to settle here, sir?
My cases are right.
You want to settle in Hyderabad?
So I just have one comment that in context to the last question which was asked to you, most of the urologists in India, they are reusing this ureteroscope, though they are meant to be disposable, but so that's why we call it as a limited use ureteroscope. And most of us are using the scope for minimum at least for 10 to 15 times. There is no locking device on this ureteroscope. Like the one you were using, the Redpoint.
I like it.
Scope.
Very nice scope.
Yeah, so it's a very good scope. In my practice, I use it very frequently. And so these scopes, and I'm using the 6.3 French also. And it's a very good vision. And tomorrow I'm going to demonstrate the 6.2 French ureteroscope.
Yeah,
So here, that's the reason Dr. Karthik asked the question that how many times you use this ureteroscope. Actually, they are not meant to be reused, but this is a limited use ureteroscope, what we call, and we sterilize it with either EPO or plasma, and but don't use it many times, and because the deflection goes away, especially after many use, and sometimes there is a fear of breakage of the scope. Yes.
That's very cool. You can see here the lower pole is completely free, except for my one thing here. Let me come over. Yes, you can see here. This is small one here. So what I do is now what I do, I will ask my nurse to wash, big wash. See, big wash by this pump. I would love to create a pump like this instead of the syringe because the interrupted pressure, the system will collapse. And look, you clean the lower pole easily with no basket. I don't know what's the future of basket, but it's less and less. I was sitting with the guys from Cook They still selling baskets in the world, but I think maybe the fans is not widely distributed. But if you know how to use the fan, you will like it. You have to balance the pressure, irrigation, and the suction. Look at me. Look at this fragment coming easily. So you have to put 40 centimeter, 60. You have to use the manual assistant like this. Look, the nurse, if you show the nurse, she's doing Venturi with me. She's doing Venturi.
Dr. Saeed, currently you are using more of pressure at the same time activating more of the suction also. Is there any way you have an eye on the intrarenal pressure monitoring?
I would love, because most of the problem now, most of the researches in the scope comes from the pressure. Because we know temperature, we control it by 20 watt, 30 watt. No, there is no problem. Before we was very worried about the frequency. But now the pressure is very problematic because I have seen cases with subtapsular hematoma, migration stone, lost the kidney. So I think the monitoring the pressure is the future. The suction helped us to reduce these problems. But still there is a problem with the pressure. We don't know how much pressure we apply with this, even with too fresh. So I think it will come, whether in the shape of the flexible protocol, because what I like it, I don't like the sensor to be the access sheet, because there's no true value. If you put access sheet in the ureter and you work in the kidney, so what are you measuring? But if you put it at the tip of the scope and you do AI and you manage up the stone, the volume, the composition, it will be. I think it will come, but I don't know if it's our generation.
Especially in cases like these surgery kidney, pediatric cases, they do help a lot.
Yes, true.
Dr. Saeed, what's your upper limit of intrarenal racing time?
What's that, sir?
What's your upper limit? How much when do you say I'm going to stop?
Oh.
Operative time.
Yeah, I think there is no way that we do flexible in 3 hours, 4 hours. Flexible in a pre-stented you can go up to 2.5 hours. In a stented patient, 90 minutes to 2 hours maximum. You cannot, it's feeling, it comes with experience. You can tell that this one does not go in the first session, so do not waste your time. We know that the operative time is the most independent factor for any procedure for complication. Laparoscopy, chair, you can do chair in 4 hours. So I think it depends on the skill of the surgeon, the availability of instrumentation. You can go fast. If you have a good car, you can go fast. But if you have nothing, you think the scope will do the operation, you spend 3-4 hours, this is not acceptable.
What would be the maximum stone size, in other words?
Listen, this is...
How far you go with your range?
Listen, I used to do 10 years ago, stack hole or something like that, but I noticed some problem because people, they follow the wrong message. Then I came back to do most of my cases at ECL many pair. I think the message here is to reduce the MIP as much as possible and to use the flexible for certain indication. You cannot say the flexible is for everything. So I think it's very easy in the hand of any urologist. That's the problem. But you need to guide them. You need to tell them this is not good. He will show you one case, but he will never show you 10 cases of nightmares.
So how do you choose MIP versus fans?
Well, if the patient, it depends on 3 factors. The patient insurance, he wants one shot. The patient stone composition, the kidney anomalies, it depends on multifactorial things. But I don't believe in a BCNL guy doing everything in BCNL. I don't believe in a flexible guy doing everything in flexible. You have to mix them in a beautiful combination. You have to master both of them to be able to distinguish which technique is good for which patient. And this is very important message. Most of the young urologists now, they think only flexible do everything, which is not true.
So they are not mutually exclusive. They do work together. They do combine.
Exactly.
So how will you decide your exit plan? I mean, if you complete all the plans.
Well, in a single kidney, if the ureter looks fine, no problem. I'm sure that there is no fragments here, as you can see here. I will leave, at least I will leave a stent for referral for 5 days. Because this patient suffered a lot and he has only one kidney. The problem if you don't leave a stent in such patients, the peristalsis is blocked in the ureter. I have seen cases that 6 hours to 10 hours, they are anuric. Because you said, okay, it's a clean, it's a single kidney, but the ureter will never walk, so he will be anuric for 6 to 8 hours. If you are lucky, he will urinate later. So put a stent for a certain time, then you remove it after 5 days. You do not take the courage to, okay, tubeless, stainless, which is a wrong message from some KOLs that I do tubeless. We are diffusing the message not between us, for the whole urologist in India, for the whole urology in the world. People, they listen to you, they believe you.
Excellent message, Dr. Saeed. Excellent. I think it's not for everything what is done by an expert can be done in always.
We'll put, you have a stent with a friend. This is a nice scope. It's a nice scope. It's we manipulate the fans easily. Look, we are all beautiful. You have enough water, honey? So the deflection is developed. So this is the lower pole. You can see the emitters, no fragmentation. One.
What is your antibiotic policy for the fan?
It's nice. It's nice, it's accepted. But the responsible broker for me is through the vision, but the torque, the deflection, it goes easily. Some scopes, they don't listen to you. So look, I am going to the most permeable, the most lower pole. This is the most one. Wash. These are clots, it's okay. Look, I can go here, you can do X-ray. This is the most lower. Do X-ray, please. Look how beautiful it is. Look, it's a beautiful deflection. The most really contrast is see, that the 7.5 makes the 10-12 like a train car. Contrast, you have just to show you that how possibly we can, there's a nice article from the guy, Gilo from Singapore, where he showed that with a fan, you need a new scope to reach 180 to 100. You cannot reuse scopes that you use 10 times to take a good deflection such a way. So in lower pole stone, use a new scope. Can you have contrast? And this system allows me to inject contrast while the laser fiber inside. Look, and then I can close the water from here, or my nurse will close the water there. And I can inject contrast. So X-ray. You can see clearly how beautiful the axis sheet. You can see, right? No, give me a good X-ray.
Can you see the fluoro image?
Yes, this one. Look at the deflection. It's almost 210, 240.
Almost parallel to the upper ureter.
Yes, and that's. I'm not going to say that this scope will reach everywhere. You have to think some anatomical variants like the infundibulum, the kidneys, but we don't know about this innovation. The scope's much better now. The fan's improving. We don't know where we go, but this, I've been in the Endourology for 20 years, it's so fast for me, it's so fast. I don't know what's coming in 5 years.
Even the access sheet going to this calyx is challenging.
It's challenging, but if you put your finger and just hold the access sheet here and do not move it, you will reach anywhere. But I don't want to see sorry. You're being grateful. See, you can suck the clot as well. Look at the clot. It's coming with you.
I think the message is that you have to use a brand new access sheet and a scope.
Yes, in difficult cases, you have to be selective, you have to be smart. Exactly, you have to be smart, otherwise you will be shocked. Then you will be in the court. Then you, I don't know. Then you will ask the senior, always take advices, assist workshop, go see other people to learn more experience. Do not be independent you.
Dr. Saeed, if you are unable to enter a particular case, have you had the occasion of using laser to incise infundibulum?
That's a very good question. It is not easy because some infundibulum will contain some vessels. So do not be superhero that you say, I will incise. Yes, it's true. You can incise only the tightness of the infundibulum easily, do not go far. But it is feasible, but it's not always easy because we have some cases like tight infundibulum inside, then embolization happen after that. because we were so greedy that we would open the whole the epithelium. We think this is like urothrotomy, which is not. Which is not. Kidney is a small organ, multiple vessels. You have to be cautious.
Point well taken. So what is the antibiotic policy for the RIRS?
Well, I give subtraction 1 gram preoperatively, and if it's infected, it's enough for me 5 to 7 days. And mostly we do urine culture before any procedure. But and I like to add gentamicin. Gentamicin is a very nice for the gram negative. I like to give 3 milligrams per kg as 1 dose preoperatively with the subtraction of 7 minutes. Nothing post-operatively, nothing at all. There is no data, there is no sense, because the patient will have a double D-stent, will have some residual fragments, so will create more resistance. So it's much better to keep them away. There is no proof that post-operatively is important as a pre-operatively. Let me show you that the junction now after manipulation. Yeah, these are some plots. You can see that it's like a vacuum machine. I go in to see the junction. These fragments coming. These are insignificant. Yes. Can you move please? Yeah, slowly. Now I'll show you the junction now. You can see the junction healthy, no problem. In fact, if you use a guide wire, no problem. But guide wires with the access sheet manipulation with the junction, you might add some, because some guide wires will create a value. So it is recommended to work with the guide wire, but if you use the fans inside the kidney, guide wire might prevent you from a true manipulation toward the section. It will twist around the fans. Now we'll go with only the scope, see the lower calyx. Again, it's a clean. Lowermost lower clean. Upper, how much laser time? It's 7 minutes. You can notice here, it's only 7 minutes. These are lots.
What's the big wash, small wash? Is there anything?
Yeah, big wash is like here, if you see. This is the pump, it's a chamber. Okay, big wash is like this, it's a big flow. Small pipe is like a rabbit bead, like this. So you have to train your nerves to how to deal with the fragments. If you're stuck, big wash, it can push 2 millimeter, 3 millimeter easily. Slightly if you do dusting, like this. Yeah. this, oh, stop. Okay, again. Suction, how much?
Where have you got all these fragments? It was looking clear for some time, there was no fragments.
You can bring them. Now, you see these fragments are true dust. You see, I put my finger on the hole, so the fragment comes to me. Now, I think I'll put a stent with a thread. What do you suggest?
Perfect. We have to have a stent. I think it's clear.
Yeah. Now, I will just explore the ureter. Do not be deceived by the upper ureter. You can see clearly the ureter is restented, beautiful, no signs of injury. I go up to the tip of the access sheet, then I put 2 centimeters away. Then I go in, outside, nothing there. This is the lower. Then I go outside, then I take the guide wire, please. Keep the pump on. Then I put the guide wire through the access sheet. I open the rubber part. One of the tricks is to pull the access sheet a little bit, because the access sheet will kink the ureter if it's inserted. Now you can see that in the screen. Go away, please. We are in 2/3 of the table, so we are inside the kidney. You can do a picture, please. Yeah, you see the tip of the access sheet. Now, sorry, the guide wire is inside the kidney. Now I'll put a stent with a thread. Yes, please.
Do you want to reach the bladder inside?
Yes, I think I have an NG2. Where's the NG2? I have an NG2. We are feeding to the Yeah, it's all down. That's a good message. Yes, I have to feed it. It's a GA. It's a spinal or quintuple catheter beside it. So just a feeding tube again. Yes, sir. And I like to give laser 10 milligram just to make the kidney, you know, it's a theory, but you have a trait or not trait? Okay, okay, not trait. No problem.
How do you screen your patients post-operatively for residual cal follow-up?
Okay, 2 weeks, remove the stent or 10 days, then I follow them 6 weeks to 3 months with ultrasound.
So you don't believe in non-contrast?
No, if you do it endoscopically, nothing there, no need to repeat the CT scan. You just simple ultrasound because endoscopic vision is enough for you. So, give me the brochure, please. Now the trick. You look at this guide one is very fantastic. It's a hybrid hydrophilic. And now I will just put my finger in the middle of the then I push up till the meatus. You will see that I am inside the kidney. Now I put them. I'm inside the kidney, so I don't care about anything. I'll go down to the bladder. Go to down bladder, please. Go down. So I'm sure that I'm a symphysis pubis. X-ray again. Okay. X-ray again. Sorry. No, more. Can you raise the table up for the gentleman? Okay. Now, go inside. Just stop here. Stop here. Now, don't. Yes. Now X-ray. X-ray. How about X-ray? What? Yeah. Now, take it up. X-ray.
So, do you have any difference in the level of pulling out the guide wire in male and female?
The guide wire, no.
The upper border of the pubic ramus or the lower border?
No. It's the middle of the symphysis pubis. It's enough for you. Unless she has a cystocele, sometimes the orifices will be below the pubic bone. So make sure that the lady, she doesn't have cystocele, otherwise the uterus will be down. You will be deceived.
I think that was a wonderful demonstration by Saeed. You drove your Ferrari beautifully. We just loved it. And I think the total lasing time was just 7 minutes, but the total energy used also was just 6.9K kilojoules. So that's also really beautiful.
That's the message. You don't need the 20 or 10 joule or 30 joule. It's too much heat. So you have to be fast and drive your car and reduce the heat.
I think wonderful demonstration. Karthik, any other questions from the floor, or we can call it a day here?
Thanks, Dr. Saeed. Thanks, Dr.
Thank you. Wonderful. Thank you. Over to you all.
Sensing a feeling of love